Welcome, everyone, and thank you for joining us. I'm Gigi McMillan, the Acting Graduate Director for the Bioethics Institute at Loyola Marymount University. The Bioethics Institute is like an umbrella over several initiatives: our Master of Arts in Bioethics, an undergraduate minor in Bioethics, campus and community outreach, annual lectures, and the O'Malley Chair. We might be weary of living with and talking about COVID-19, but one topic that has not yet been comprehensively addressed is the increasing stress in hospitals as the pandemic took hold, ebbed, and then returned again and again. Tonight we will hear about the experiences of 3 people who have been on the job since the very beginning. Felicia Cohn is the Bioethics Director at Kaiser Permanente in Orange County, and Thomas Cunningham is the Bioethics Director at Kaiser West Los Angeles. They are joined by Dr. Nicole Rae Van Buren, a palliative care physician and ethics committee co-chair. Welcome, Dr. Cohn, Dr. Cunningham, and Dr. Van Buren. Thank you for joining us. And let's begin with Thomas Cunningham.
I'm honored to be a faculty member in the Bioethics Institute at LMU, and very happy to have been involved with working with Gigi and the other members of the faculty there for many years. My background is in philosophy, specifically philosophy of medicine. I took my PhD at the University of Pittsburgh in history and philosophy of science and my master's in bioethics there. And I also have a background in bench science, doing benchtop biology and getting a master's from UCSD. So I want to start by saying a little bit about the overview of what I'll be talking about today. We've allocated about 20 minutes to each speaker, and as Gigi mentioned, we'll have conversation afterwards, and we look forward to responding to your questions. What I'm going to talk about is what it was like at the beginning of the pandemic, before anyone knew what this thing was going to be, before anyone was talking about the massive numbers of hospitalizations in the United States. So the time period about mid-March of 2020. Then I'll talk about my experience working with colleagues in the hospital during the first and second and then third wave. And that's where I'll end my portion of the talk. And that'll include a little bit about preparations for crisis care, which we never implemented. And then Felicia will take up a time period after the third wave, and then we'll kind of proceed chronologically to Nicole's part of the presentation. What I'll be giving is a first-person narrative. I'll be telling you my experience and my perceptions of others. I don't have any slides. I want to thank the Bioethics Institute and Gigi for inviting me to give this kind of talk. It's an unusual kind of academic talk. It's less about data and scientific claims and the kind of things I write about in my scholarship, and more about what was it like to be there. And so I hope that is well received by the group. But it's worth saying that I'm not representing Kaiser Permanente here. I'm also not representing Loyola Marymount here. I am telling my story, and so please know that that's what's going on here. So let's start with the beginning. In the beginning for me, the pandemic started while my wife was away on an all-women surf trip in Maui between March 8th and 15th of 2020. I know that's a pretty stereotypical Southern California dude kind of thing to say, but it's true. She was away in Maui, and I was taking care of our kids and going to work, which was all fairly normal happening back then, but in the before times. I'm a news person, and I also, as I mentioned, trained as a biologist prior to moving to philosophy and bioethics. And my best friend happens to be an epidemiologist. So when the news started saying more and more about a worrisome virus in Asia, I kept reading. I'd also been recently asked to represent my bioethics peer group. There are 11 of us who work in this group in Southern California on a regional emergency preparedness committee covering the 13 hospitals across our health system, although I had not attended any of their meetings at this time. My peer group had a regularly scheduled meeting on March 9th of 2020, and I asked for some time from our leadership to give a presentation on this worrisome virus in Asia. I titled the talk, ethical allocation of care during crisis and austerity. The purpose of the talk was to summarize what was known about the risks of what we now call COVID-19 and what ways ethicists might respond. My conclusion then, and I quote, was, overall, the review reported here concludes that there is a potential for extraordinary risk in the event that circumstances of crisis and austerity arise and allocation decisions are made without proper concern for legal and ethical justifications for making those choices. It is recommended that more work be done to clarify the potential for risk in the setting of crisis and austerity. I don't remember when I prepared the analysis, but it must have been in early March. But I reviewed sources from LA County, Oregon, Seattle and King County, Washington, New York State, the Institute of Medicine, the CDC, Michigan, AHRQ, academic literature, and news sources. These ranged from publications in 2009 all the way up to things that were current at the moment in March of 2020. 3 days later, I presented a similar slide deck to our hospital bioethics committee at Kaiser Permanente West LA, which I co-chair with Dr. Van Buren. By that time, I had discovered a Johns Hopkins University website which tracked confirmed cases, which at the time were 127,863, total deaths from the virus, which were 4,718, and the number of recovered patients documented, which were 68,310. Those numbers seem absurdly small today. The fourth slide in that presentation is titled, "Is it possible COVID-19 will cause a pandemic crisis in the US?" My answer looked to news reports, epidemiological models, the long length of stay for COVID-19 patients at that time, which was 14 and a half days on average, and the low ratio of hospital beds to persons in the US to make the conclusion that, therefore, it is possible that COVID-19 will cause similar crises in some areas of the United States. That doesn't necessarily mean here. The slide deck concluded by recommending flattening the curve and that the Bioethics Committee begin working on our plans to respond to the pandemic locally. The last slide concluded with 2 bullet points. The first was, how will you care for colleagues, loved ones, members, and yourself if things get real? The second one read, how will you position yourself to care for others and yourself after the crisis? Although I'm proud of how prescient I was at the time, I'm also humbled by my all too human limitations. We still don't have answers to these questions. I still don't have answers to these questions. I don't remember when our first patient who tested positive for COVID-19 was hospitalized at my hospital. I think it was mid-April of 2020 or so. All I know is that my hospital and Cedars-Sinai, which is 3 miles away, were the first in the area to start accumulating patients. At this time, the issue wasn't the dreaded surge of patients that I described in my ethics committee presentation. The issues were uncertainty, fear, and scarcity. There were few reliable sources of information about the virus available at this time, and many sources of unreliable information. That's a hallmark of uncertainty. Healthcare providers understood their obligation that it was still time to work, perhaps never more than before. But we were afraid, and to be more honest, they were afraid. The doctors, the nurses, the respiratory therapists, the medical technicians, and other bedside workers in the intensive care unit and step-down unit were afraid. And this is an important distinction for those of you who are familiar with the frontline heroes kind of metaphor. There are a lot of different ways to be frontline, and they all matter. But here I'm talking about the people who were bedside in the intensive care and step-down units, who were the most proximal to the suffering and the disease and the morbidity and mortality of that time. Sometimes they would reveal their fears in hushed conversations. Sometimes it would come out in a public meeting. Sometimes I would see them crying as they changed out of their PPE. I recall hearing a physician tell her children on the phone she didn't want to infect them and she couldn't trust herself not to get sick. I think this was in May of 2020. She was in the command center, and this was between seeing patients. Our ICU had gotten busier than most in the area, and we were the first hospital in our company to go into emergency mode. I worked in the command center at that time. My job was to develop a sophisticated way to track our PPE to make sure that the right people got it when they needed it, and that none of it was wasted, lost, or stolen. I had to tell nurses they couldn't have more. I remember this now, and I'm a bit ashamed about that. But someone had to do it. It was the right thing to do. We didn't always have enough at any given time, and the burn rate for some supplies told us that if things got worse, we might come up short without being able to predict what that would look like. One of my responses to the uncertainty of this moment, based on the trouble I had finding reliable sources of information, was to start a folder in my personal Google Drive where I put all the reputable sources I was reading. A colleague, Janet Malik from Baylor College of Medicine, asked a group of ethicists on our big listserv, the Clinical Ethics Consultation Affinity Group, around this time if people would share state or institutional policies. In response, I shared the folder and made it public. Colleagues from around the country sent me documents to post, making it easier for all of us to rapidly process the information as we tried to understand what was happening. One thing that was happening is that we were seeing more COVID-19 patients. It's worth hearing about the typical kind of patients we were seeing at that time. As I recall them, they were older, like in their 50s to 90s. They were more often than not racial minorities, Black or Hispanic, and more often than not men rather than women. And they were very sick, often intubated within hours or days of coming to the hospital on very high levels of oxygen support and with very poor ability to breathe. As I recall at this time in the first wave, the survival rate for intubated ICU patients was around 20 to 40%. That's the survival rate, as in just leaving the hospital alive. Obviously, most did not. The time between the first and third waves took place over summer to fall of 2020. Notice that in many areas of Southern California, there was what I think we will eventually look to as a second wave. At my hospital, we did not experience this in the way others did, since we were part of the first wave. My time during this period was spent in planning, program development, and education. In those early days of March, my initial peer group presentation was persuasive. My leaders asked me to present the same information to a larger group, which I did. If you can imagine a cartoon where a snowball rolls downhill and flattens a character while building and rolling a long, long way until something dramatic happened, well, that was me. I was caught up in this snowball. I worked with all sorts of people, other ethicists, physicians, administrators, data scientists, and so on, to develop plans for responding to a surge so big it becomes a crisis, in the sense of the now ubiquitous concepts of normal, contingency, and crisis care. It took months for us to develop draft plans for allocation of short critical care resources in the event of a crisis, based on a thorough review of internal and external materials. Initially, we had a draft in April of 2020, but then the state of California released a draft that differed in important ways from ours. As we made revisions, so did the state, which eventually released theirs in June of 2020. I cannot summarize this time in my work now, but I'd be happy to take questions about it later. What I can say is that I worked like an insane person. I was constantly on the phone or the computer. I spoke often with an old mentor from Pittsburgh who is nationally recognized for his work modeling crisis care allocation. I spoke with reporters on occasion, almost always anonymously. I worked in the command center during the weekends and sometimes weekdays. I read whatever I could. I talked to the physicians and staff of the hospital whenever they were available. As I alluded to earlier, something that became plain to me was that no one was going to be the same after this. I couldn't predict the great resignation we are experiencing in society right now, but it was clear that anyone working in the hospital was going to be changed. Anyone who was on site in the facility was going to have some sort of distress and change and new experience from all that we were going through. Everything was just too unusual, too disturbed, too upset, and for those closest to the patients, too traumatizing. I was right about that too. On December 7th, 2020, I gave an invited talk to the National Institute of Health Bioethics Interest Group, which I titled 9 Months, Yet No Delivery in Sight, Doing Ethics on the Front Line of COVID-19. The first half of the talk covers what I've told you here today. The second half focuses on 3 issues that concern me: family clustering, visitation restrictions, and what I called at the time, rationing in multiple dimensions at once. Briefly, family clustering, which is based on a paper Dr. Van Buren and I published in the Hastings Center report with two colleagues from Kaiser Permanente, is when multiple family members all become severely ill from COVID-19 at once. Cases like this are where a husband, wife, grandparent, daughter, and other extended family members are all so sick at once that they're all hospitalized. More than one person is in the ICU, and others are at home so sick that they can't function well. In our work, we highlight the grief and trauma this causes for patients and providers, and the problems with surrogate decision-making for incapacitated patients that follow from having everyone super sick and no one in their right mind available to make choices for the patient based on the patient's values. Visitation restrictions are another source of widespread distress for the public, patients, healthcare providers, and hospital administrators. They are necessarily a source of injustice, since the state provides regulations to restrict visitation, but provides no resources to support compassionately involving family members in care when they cannot be present physically in the hospital. Nor does the state provide any mechanism for making exceptions in special cases and being patient-centered and family-centered based on those special cases. These must be made by the healthcare system or hospital. And rationing in multiple dimensions at once is another source of distress. I describe that as covering a situation where there are shortages across multiple dimensions. Shortages in medications, in hospital staff, physical space, in PPE like gloves and masks, and in available vaccinations and so forth. Recall that this was, right at the beginning of vaccinations being available and only to the frontline providers, and only at the very earliest time. It was common at this time to learn that we had a few days supply of some emergency medicine or something else without knowing what the planned workaround was going to be or if there would be one. After my talk at the NIH, things got much worse. From December to January, we experienced the worst surge, the third wave. Without going into numerical details, I can just say that all the hospitals I'm familiar with around here experienced patients at 200% of capacity or more. To give a hypothetical example, that means that if you have 25 ICU beds available for a normal week, usually 15 to 20 of those will be filled up with patients. In this situation, 50 of them would be filled. And in the audience, you should wonder, how do you fill up an intensive care unit past capacity? That doesn't make sense. It's not like water. You can't just double the size of your bucket. And that's correct, but it's also not. Hospitals literally created new beds out of pre-existing spaces. They engineered them to be capable of supporting patients needing intensive care. A hospital like mine went from a typical volume of 125 patients to 250. As you can imagine, there's no business plan for finding and paying for all the additional doctors, nurses, respiratory therapists, social workers, janitorial staff, engineers, administrators, and so forth necessary to make a hospital function at 2 times its capacity for many, many weeks. Hospitals typically have the right amount of people available to make them function based on typical expectations. Double those volumes and you just don't have the right amount of people. And what happens in this setting is suffering. Everyone's trying their best to do their job and other jobs, and do all of those jobs twice over because there's twice as much work to do, or even more. And all the while, they're worried about getting infected. Recall that this is at the very beginning of when vaccines were available. And those who got infected got sick to various degrees, having to quarantine, suffering from loss of human contact, and being unable to provide the caregiving labor that is the source of their professional identity. I recall being in the ICU with a nurse whose father was also in the ICU at the same time. He told me he was grateful he could be close to his father because no visitors were allowed. He couldn't care for his father because it was too much for him to bear, but he was grateful to be near him. His father died during that admission. During this time, I spent nights working ICU shifts as a kind of a extender of the hospital staff, doing what we would call scut work to help out the providers caring for patients. I did this 12 hours twice a week while still working my full-time normal job. It was Christmas and then New Year's. I think I did this for like 8 weeks. I remember moving bodies from one part of the hospital to the other. I'll never forget this. Some people do this normally any given day, as those are their jobs. But it seemed unusual to be doing it 10 or more times a day during the hardest of times. All the suffering, it was just ever present, and I'm not sure we can or will exhume and repair the impacts of that suffering. it may not even be worth it. We may just have to do what the bumper stickers say and keep calm and carry on. That's not all I have for you. Thank you for this time and for this platform to work through my experience during the beginning of COVID and through the third wave. I look forward to our discussion.
Thank you, Thomas. Felicia, I'm very curious about what you had to say about the middle part of the journey.
Yeah, so picking up where Thomas left off, and I'll echo his statements too, I am representing my own views, my own observations, my own experience, and speaking from the heart about that. This is not an academic presentation, this is an experiential one, and not representing the views of Kaiser or anyone but myself. I want to focus on three things. First, trends in the physical experience over time. And second, trends in the moral experience over time. And then finally, questions regarding the role of bioethics in addressing the crisis or would-be crisis. First, regarding the physical experience, there are a number of shifts that seem to occur. I would target between the second and third surge, and these really had to do with fear, trust, and fatigue. First, there were differences in the level of fear. Initially, everyone was afraid. Walking in, it was like going to the moon. Everyone was in spacesuits. We were so afraid, everyone was covered, everyone was distanced. I was told at one point, after dealing with a difficult family over a visitation restriction by one of our leaders, to go home and to not come back unless I needed to be there. We didn't have the PPE, we didn't have the space, and people would be afraid if I walked into the units when I didn't belong there. But there was so much fear. And over time, that lessened. And that was before the vaccines became available. We started becoming more accustomed, and people weren't in the spacesuits. They were double masked, they were distanced, they were still taking all the precautions, but it was different. The fear was declining. And I don't know if that was because we felt like we had a better handle on what was going on, what we were doing, if there was more PPE, or if we just became accustomed. All the virtual meetings gave way to more in-person experiences. So, I had been doing family meetings by screen. I had learned to do my job without seeing people in person. I'd had family meetings on the phone, which I got to tell you is really difficult, without body language, without being able to hug people, without being able to hold someone's hand, lay a hand on their shoulder when they're distressed. It was really hard to have those family meetings by phone. But suddenly we were having some family meetings in very large rooms in person again. So that was a radical shift. Masked, distanced, but a little bit more in person. I think there was a felt increase among the physicians in their competency to take care of the COVID patients. They were learning. It was fascinating to watch the clinicians, the physicians, the nurses learn how to take care of patients with this disease. The way we took care of them changed, when we would intubate, what drugs we would use, how we would relate to the families really changed throughout the course of the last year and a half. And I felt like there was a greater level or a sense of competency. They just felt like they knew more what they were doing. They were more confident in the care they were providing. They felt more confident that they could save more people. And then finally, in terms of physicality, the initial adrenaline burst that kept everyone going had long since worn off. And the ongoing fatigue as day blended into day, week into week, and month into month was exhausting. And everyone awaiting the next surge. So rather than not being excited, but being ready, being there, ready for the next challenge, there was a dread going to work every day. When is this going to change? When will this be over? And there was no light at the end of the tunnel. But these shifts really, I think, affected the moral climate as well. So those trends in the moral experience over time. Physicians, I think initially, all the healthcare professionals initially were more comfortable with letting go. The patients weren't doing well. That was in the news, and their families were aware that patients didn't do well. If you got to the ICU, particularly if you got intubated, it was bad news. And you could often anticipate that that was going to lead to the end. And at the time, the physicians were a lot more comfortable writing what we call unilateral DNR orders. They would just tell families, your loved one is not likely to recover. We're not going to resuscitate. It will do harm and will not benefit the patient. And that started changing over time. As their knowledge of COVID grew, as their confidence in the ability to treat the patients, they were less comfortable. And I'll say the families started being less accepting of mortality as well. So initially, the families recognized these signs that a patient was not likely to leave the hospital. And that shifted through that second and third wave into a refusal to accept that we couldn't fix it. Similar to the way we experience other illnesses, where families don't accept that just because someone has advanced cancer, it means they're going to die, or advanced heart disease, it means they're going to die. Families don't accept those and have long, I joke that it's part of why bioethicists have jobs, because we refuse to face mortality and accept that none of us are immortal. And that started becoming true with COVID as well. As there was more news about treatments, more news about better survivability, the families stopped accepting that their loved one would be the one who wouldn't make it. And that was really difficult for the physicians. And it was compounded by the demands that some families started making for treatment plans, treatment modalities that research suggested either would not work or would actually be harmful. And yet these things were in the news. People were asking and trying actually even to sneak into the hospital to the patients, ivermectin, hydroxychloroquine, all kinds of other treatments that they claimed would help, because there are websites, there are physician testimonials, there are people telling them this is what you need to do to help your loved one live. And that became even harder for the doctors, because now they had to say, no, I'm not providing that, and face the backlash of the families who wouldn't accept that their loved one might not make it, and wouldn't accept that we weren't offering various treatments that they were demanding. So there was more vitriol from the patients and families, really in the by the fourth wave than ever before. There were these radical and often rapid changes in the visitation policy. So not only were we telling people your loved one's not doing well, but you can't see them either, until they're actually dying, imminently dying, we're not allowing visitation. So there was a lot more anger, and the tension really was interfering with that shared decision-making process, which again was mostly happening by phone, because these family members weren't allowed in the hospital. That made communication a much more difficult process. Which brings me to this role of bioethics. What were we doing? What were the bioethicists doing during this time? As Thomas noted, we were pulled into this planning process. I would say Thomas jumped into it and maybe dragged the rest of us along with us, but it was happening around the country, and for good reason. We played these games in graduate school. The distributive justice game, the who gets the ventilator game. We all had those classes, and they were all hypothetical and fascinating to see how different constructs emerged, different biases took shape, different plans came about. And yet here we are in this real life game of distributive justice. And so it made sense to me that we were being asked to help develop these plans, consistent with guidance from the state, trying to maintain some consistency throughout the country, so that a patient who would get treatment in California would also get treatment in Nevada or Washington or Nebraska, anywhere else they were. to the degree possible. So it made a lot of sense to me that we were involved in that. But, the state guidance was slow in coming and not always as transparent as we probably would have liked. And around the country, plans were evolving a little differently. So it became real difficult. And it was beyond the grad school who gets the ventilator game. This was real. And we were all terrified that we would actually be called into operationalizing those plans. Which brings me to my next point, that we were asked to operationalize, or at least to plan to operationalize, to get ready if the contingency became a crisis. We were putting the teams together. We were the people in charge, which I found really interesting because bioethicists typically provide advice. We offer recommendations. We don't provide the care. But here we were in charge of this process where we would be deciding with our teams who got what and when. And I always questioned if that was an appropriate role for us. And I understood the backdrop that everyone was being pulled into doing things that they had never been asked to do before. We had pediatricians and anesthesiologists rounding on ICU patients. We had administrators providing nursing care. I mean, people were being pulled into roles that they normally would not be undertaking, with whatever training we could muster at the time to keep our patients as safe as possible. But I still wondered, is this really the right role for the bioethicist? Those of us without support staff, without authority, without budgets, getting pulled in to leading these really serious efforts. And the plan itself remained both insufficient. It was not an optimal allocation schema. There were so many missing factors and so many challenges, from the clinicians, from the public, things that were going to make it really hard. And it was unspecific. There were so many details missing. We wanted to assure consistency across settings and to reassure clinicians and patients and families of fairness and to decrease their anxiety and to decrease, frankly, the anxiety of the bioethicists and their crisis triage team members. And yet we couldn't, because every time we would run a scenario, we'd do training exercises, we'd find more unanswered questions. How do we really know which of these two patients gets the ventilator? When the reality was, it wasn't just going to be between two patients. It was going to be which 5 of the 100 patients gets the ventilator. And that was just mind-boggling to consider. It was unclear what the resources we were going to have to put all this plan into place were really going to be. It was unclear of our authority to actually activate a crisis triage plan. Who would say it's time? When is it crisis? Is that going to be a local decision in the hospital, a regional decision, a state decision, a national one? And how do we manage all of that? And then would they actually, the clinicians, actually respect the authority of the decisions made? Would the doctors rebel? If I went and told the physician, I'm sorry, your patient cannot have a ventilator today, would they respect that? How would they push back? And what would that look like? What would it mean for the other patients who were getting the ventilators? And how do you tell the families that your loved one is the one who lost in this horrible lottery system, whatever that's going to look like? And then there were requirements for reporting, but not really good mechanisms for collecting data. So how are we going to manage that? How are we really going to keep track? And if next week somebody asked me why patient A got the vent over patient B, could I really go back to the data and explain that, justify that in a reasonable and understandable way? So it created this situation where we all felt like we really didn't know what we were doing, but we're doing the best we could at the time, and praying that we really wouldn't have to do it. And every day, going to bed every night, that was my last prayer, that I am spending all of this time and it will be wasted. And there was this disconnect I felt between the surge planning, though, and the crisis planning. there were unclear lines about when that shift would occur. And it created a situation where I think rationing was occurring, though we didn't call it that. And it was not being done in accordance with the state guidelines, with the national consensus, with the local practices. Nursing, for example, was stretched beyond all reasonable limit or possibility. You know, the ratios that were acceptable during that time would never be acceptable at any other time. Yet we had to live with it because it was all we had. We had nurses who were quitting because they were overwhelmed, exhausted, getting sick, frustrated, taking care of sick loved ones, or being lured away. The temptation for these risky but lucrative travel nurse contracts. So, you know, why work here at my home hospital when I can make 2, 3, even 4 times as much if I am willing to travel to New York or elsewhere, anywhere experiencing a surge worse than our current one. So we were losing people when we needed them the most. The physicians were making really difficult decisions about everything they had to do. Calls from my ICU physicians, from my internal medicine physicians about code status, about giving the medications we had on hand, how to allocate those things as fairly as possible. And these things were keeping them up at night. They were worrying about every patient they had, which is again what was making me question whether they would respect decisions to limit treatment. And there were calls from specialists. You know, I had several from very distressed nephrologists, actually was one big example, questioning whether it was okay to dialyze short, to run dialysis for an hour or 2 instead of the usual 3 or 4, to do it every 3 days instead of every 2, to dialyze at 2 a.m. because that's the only time when a machine was available. Are these things okay? And on top of being exhausted, they were worrying about the resources they had to give. And yet we weren't rationing. We weren't doing crisis triage yet at that time, but we were. At least that's what it felt like. And then addressing the role of healthcare professionals in all that was going on at the time and continues to go on. What is their role in dealing with the disinformation about treatment, about physicians supporting treatment that has been proven ineffective or harmful? How do they address that? What is their responsibility there? And how do they face it when the families come in with these issues? Vaccinations has, our great white hope has turned into yet another ethical morass because people are refusing. Even people who we would think should know better. People who spend their days taking care of these really sick COVID patients, some of them are still refusing to get vaccinated themselves. People who've had COVID refuse to get vaccinated among clinicians. And what is our responsibility there? How do we address that? And then the vaccine mandates. Is that okay? Should we be requiring healthcare professionals or not? And the state has decided that yes, we are. The country has decided that yes, we are. That those who take care of others have a responsibility to take care of themselves. And that makes sense until someone challenges it with good reasons. And the religious exemptions that people keep asking for and about, how do we address those? When no religious organization that I'm aware of has come out to say it is against our religion to accept this vaccine, and yet individuals claim religious exemption regularly. So how do we address that? And what is our role there? So we're caring, and then the issue of caring for patients who have refused to get vaccinated, and this sense that they are doing it to themselves, which, I've tried to talk to some of our physicians about. Is it really any different than taking care of a diabetic patient who's non-compliant? Who continues to eat candy bars and ice cream every chance he gets, to our heart failure patients who don't change their activity, to any of our patients who don't take care of themselves. to those who choose voluntarily to take risks. When you could make that argument about clinicians and grocery store workers themselves. They are putting themselves in harm's way, given the virulence of this disease. Yet we take care of them, we care about them. But there's been real anger I've sensed against people who have refused to be vaccinated and end up in our ICUs. So how do we address all of that? Overall, there's concern that each individual and the organization that they work for be on the right side of the issues. But we don't really know what that is. And we know only time will tell what ultimately was the right side. And it will feel really hard and terrible not knowing how history will judge this time in our world until later. So thank you all for listening, and I'll look forward to our question and answer period.
Thank you, Felicia. I just want to remind everybody on this Zoom meeting that you can type your questions into the chat. I've already been collecting a few. And now we will hear from Nicole. Thank you.
Hi, everyone. A lot of what Felicia and Thomas had already talked about will be similar themes because they're just similar themes going along with being the first people to deal with the pandemic. But I guess my view will be from my own personal perspective and that of a physician, a palliative physician during the same time. So when I think about the beginning, with Thomas, I think the first canary in the coal mine was we had a retired physician who used to be on the bioethics committee, but he still would come into some of our meetings. I think he sent an email in like very early, either late February or early March. And he's like, you know, there's this virus going in China and it's spread to other countries. I think it's time for us to be thinking about triage. And we both get this email, and I'm embarrassed to say it, but I literally texted Thomas, like, what is he smoking? Like, why is he talking about this random virus that probably hasn't affected many people, way on the other side of the world? I'm like, we've got like real issues to solve in our hospital that are going on right now. Like, what is he talking about? I thought he was being an alarmist. And then the Lakers got canceled and all these sporting events got canceled, and then school was canceled, and then curfews were implemented, and life as we had known it was never going to be the same again. So I had to, say, oops, my bad. This is a real thing. And like Felicia said, Thomas goes looking for trouble. So he immediately started to think about how bioethics could kind of shape the course of how we confronted this pandemic and how our hospital could kind of be a leader or try to be a leader in how we manage it. And so he dragged me along into two initiatives. One was the visitation policy, and one was the triage, the triage crisis committee, which we called it, which was basically allocation of scarce resources that Felicia also talked a lot about. And I really hadn't been used to developing policy, but Thomas was a great mentor to me. And I think initially, because I'm a palliativist, I'm usually way so far in the empathic scale. I was like maybe trying to overcorrect for that. And I was initially very much like, we got to keep these patients safe. We got to keep the community safe, public health. Like, nobody should be able to visit their dying one. I mean, it's crazy to think about that. I mean, even the area medical director was like, well, if palliative says we need to like lock down on visitation, then we absolutely should. But that was the beginning before I had to do so many basically be the surrogate for so many families that couldn't be there to comfort their loved ones as they died, hold their hands, play the music they liked, whisper sweet words in their ear, that kind of a thing. In the beginning, they were redeploying a lot of physicians into other areas. So maybe the eye surgeon would be doing, or the eye surgeon or the dermatologist or the rheumatologist, the specialist basically, might be redeployed to do emergency medicine work. The surgeons were redeployed to do ICU work. They were trying to redeploy the palliativists to do other work. But, we kind of said, look, people are dying in unreal numbers. You're going to need more palliativists than you even had before. So we really need to we need all the palliative support we can get. And we did. We worked around the clock. I personally volunteered to do 6 weeks of just ICU COVID work. I ended up having a bit of a mental breakdown, my first in my whole career. But I think what brought it on was just kind of like Felicia was already talking about, the incessant phone calls. It's like you're having the same horrible conversation 20, 30 times a day. Your loved one's dying. They're not going to make it through COVID. No, you can't come see them. We expect them to die today. And yeah, sorry, you can't be by their bedside. And you have this conversation enough, no matter how good you are or how empathic you are, it just becomes kind of absurd and robotic. And I think families can pick up on that. And I think I was at the end of my 6 weeks, and I had been talking to a woman who was in her 40s. Her husband was in their 40s. They had young children. And the ICU doctors were so busy, they couldn't even really update people, in a timely fashion. So they would depend on the palliative team a lot to update the families on basically the poor status of these individuals. And so I got tasked to do that with this one woman. She didn't expect my call. She certainly didn't want to hear the message I had to give her. And she kind of just unloaded her grief all over me, as she should have. And I, you usually don't take that personally, but I think after 6 weeks of saying the same thing day in, day out, it sort of just becomes kind of unreal and absurd. And she just really unleashed on me, called me all kinds of names, very inflammatory. And I felt so bad, and I was apologizing, and I just felt awful. But she hung up on me. And then after that, I just sobbed, I cried, I boohooed. I think it was for 6 weeks of having to have these conversations and be, the one at the bedside telling the family members, I was there when your loved one died. I held her hand. This is what she looked like before she took her last breath. She wasn't alone. I think it just kind of all caught up with me, and I lost it with that one wife in particular. So I promptly called my colleague and I said, I'm done with wards. I'm not coming in on Monday because this happened on a weekend. And I said, I'm just not doing it. I don't care who's going to cover me, but someone's got to cover me. And my colleagues, thankfully, they understood. They were great. They stepped in. They supported me. I got a little bit of space from that time. And so, I think that's one thing that came out of the pandemic, at least from us on the front lines, is that it's kind of like being in a war together. I think especially doctors have a lot of ego, and when things are kind of status quo, you can kind of be like, well, this doctor doesn't know what they're doing, but I know what I'm doing, such and such. But the beginning of COVID was kind of like being in a war. And I saw that the doctors, at least, and the staff and everything, we were more compassionate toward each other, more understanding, more forgiving, because we kind of all knew we were at our limit, the end of our rope type of a thing. So when I needed to tap out, I had tons of support, and I'll never forget that. So that was a little bit about that. So Thomas and I worked for months and months trying to create a wonderful visitation policy. And it was actually that's that's the funny part. So I'm the palliativist. I'm like, nobody should visit. I'm worried about infectious disease. It was our infectious disease specialist who actually, because she understood, the risk of infection so well, she was the one that was able to make our visitation policy more humane, find a way for it to still be safe, yet still be compassionate and allow more people to come. I mean, the big risk then was that people weren't vaccinated. So anybody who's a family member of a COVID patient, we'd wonder, are they positive? Are they going to be bringing in COVID to the hospital? If they're not COVID positive, are we going to be exposing them to COVID and then they leave with COVID? That was the big one of the big problems. In the end, I think we decided that people have the right to take their own risks in a way. If we give them proper PPE, they know their risks. Who are we to deprive them the chance of saying goodbye to their mother, saying goodbye to their child, their brother, their sister, whatever. So we ended up coming with a really great policy, and it felt very nice because I think our center was working very hard on the policy. And the irony was that we were working on this great policy. We couldn't get our local people to enact it because Region hadn't accepted it. But Region ended up using, I think, our policy as a sort of template. Once they approved it, then we were able to use it locally. So I got to learn a lot about kind of how policy works within our system. And the other thing was the triage, which was very surreal. We worked, all of us. This was like region-wide. People were working on how do we get an algorithm that's not biased? You can't. That will save the most lives as possible. That was always the goal. The goal was to save as many lives as we could. And to do that, you have to acknowledge the sickest people who are not going to make it. We don't want to deprive people who would make it based on quasi-objective criteria. We don't want to not give them a chance because we're doing like a first come, first serve type of thing. That doesn't serve anyone either. But it felt very icky to have to ignore personal stories of a human being and reduce them down to a number when it comes down to it. And these numbers were ever changing, minute by minute. Somebody had to be staffing this Excel sheet, this algorithm, 24 hours a day. I'd wake up, I'm not a morning person, but when this was going on, I'd wake up at like 6:30, and I would start assigning people numbers based on our algorithm, based on our triage criteria. And then you would rank everyone. And it's weird to work so hard on something that you hope you never have to use. Like I think Felicia mentioned, the closest we got one day was we were down to 4 ventilators in the hospital. And then that's when we really were like, oh crap, we might actually have to enact this. And I just got this like the sickest feeling in my stomach. But luckily in our integrated system, we were able to borrow ventilators from another center, and we never got that far. But that's the closest we got in my recollection. But then as the physician co-chair of the bioethics committee, it was my responsibility to promulgate this whole idea and this whole protocol to the rest of my colleagues. And it was very rough, to say the least. A small subset of the physicians understood, like, obviously, this is all of our worst nightmares. This is not why we go into medicine. We go into medicine to save lives, not try to deny interventions or care to certain people. What a lot of doctors weren't able to step back and understand is that in order to save the most lives, we do have to have some sort of organized process in doing so. Not only that, it was a state mandate that we have a plan for this. So this is like work nobody wanted to do or have to teach or enact. But it was what it was. And I got a lot of pushback from my physician colleagues, very upset, angry, kind of yelling, very emotional, like, I refuse to be a part of this. I'm not going to communicate any of this to the families. I'm supposed to be their number one advocate. I should be advocating for them to get the ventilator or the treatment or whatever. I will have no part in basically conveying the language or having the talk with the families that their loved one may not get a resource. And that was just really challenging because I think, from one side, I was like, oh my gosh, my colleagues think I'm like this like devil doctor who's like enjoying this. I'm absolutely not enjoying this. But at the same time, you have a medical, doctorate behind your name. You are an MD. You've taken an oath to, help and heal as many people as you can. And sort of, you know, heavy is what the head who wears the crown or whatever. Like it's something that we don't want to do, but who else is going to tell these families what's going on? It has to be the doctor. And we have to all be in this together and all be on the same page. It doesn't help for some doctors to be, very anti this, and some doctors, in any case, thank God we never had to use it. I still worry if we ever did come into those circumstances, how our hospitalists and our whole medical center would deal with it. I think it's something doctors are it's such a cognitive dissonance. It's just so anti what we've been taught and go into medicine for. But these are desperate times calling for desperate measures. You need a leader and you need someone with a cool head to make those hard decisions. And if it's not your doctor, who is it? And we have the backup of the bioethics team. We have their support. We have the support of the administration. It's obviously not our call. So I think that was kind of hard in trying to ease my fellow physicians' concerns about that sort of thing. Also in this process, as Thomas and Felicia talked about, I was able to participate in writing a paper that got published, and it was also very much like this, kind of about our observations and personal experiences and what we've noted during COVID. And so our paper focused on three main themes. One was the lack of acceptable surrogates and decision makers due to either everyone in the family being sick at once or surrogate being sick themselves, or what have you. There's a number of reasons why the surrogate decision maker, when we needed to make shared decisions, was suboptimal at the time of COVID. So as a palliativist, of course, I'm very interested in that because my whole job is to talk to people, either the patient or their surrogates, about shared decisions in seriously ill, in serious illness. So that was a challenge. The second part, we talked about the different emotions and how it's different. This was different than other grief from family members, from maybe their loved one being seriously ill with a different issue. So particularly with COVID, you had guilt, a lot of guilt, because many of the times it would be the family who had inadvertently given their loved one COVID and, obviously didn't mean to, but now their loved one's dying of COVID. You'd have a lot of complex and really burdensome feelings about trying to transition to comfort focus or de-escalate intensive interventions if you were the one who had given this disease to your loved one. Similarly, there was denial. We had, many family members were infected at the same time. They had survived with little to no symptoms, yet their loved one is dying in the ICU. And that was a huge disconnect for families, especially because they couldn't visit at the time, really. They couldn't see them. So they're just kind of hearing from the doctor over the phone, your loved one is crashing, their kidneys are failing, they're on maximal ventilation support, they're not going to make it, they're dying. And the family's like, well, we all had it, we're all fine. They just need to, buck up, get over it. I literally had a family, the son was due to be married next week. And I'm talking to the wife and I'm saying to her, your husband he's actively dying. He's not going to pull through this. And I'm telling her all of this, and it's like really hard for me to say. And it's almost like she didn't hear anything I said. At the end of my whole speech, she said, you need to go in there and you need to tell him our son is getting married next week and he needs to, get over this so he can be there. It was like she hadn't heard a thing I said. She's like, we had all had it. Our son's getting married. Like, he just needs to snap out of it. So there was like a huge, huge denial that I had never really ever witnessed before. But I could see, if you've overcome it, it's hard to know because COVID hit everyone so differently. And that was even a shock to doctors. We were like, why is this person dying? This 40-year-old something, with not a ton of comorbidities. Mostly people had obesity, maybe a touch of diabetes. A lot of people in this country have that. Why is this person dying of COVID? And yet this person's gonna live. And this person has no symptoms. This person might have a sore throat or a runny nose, and this person can't breathe. It was just beyond, we were kind of walking around, doctors not knowing what we were doing, what we were treating, it was like a flip of a coin. And it was very demoralizing. What else? What else can I tell you about what I went through during the space? I guess the difference between the first and the third wave. The first wave was just all new. The third wave, we knew what we were doing, but it was just overwhelming, the numbers. The numbers were overwhelming. It was kind of like being in a war zone again. There were parts of the hospital that I'd never even seen before, basically like broom closet areas that were turned into triage places. And you go just down the line, every patient's about to be intubated, already intubated, and I'm holding up the iPad, basically in a tent, saying to the families, say goodbye before they get intubated, because you're probably not going to see them again once we do that. Once they're intubated, the mortality rate was about 80%. So if you ended up needing to be intubated, 8 out of 10, that would be your last conversation. And then vaccinations came. And so then the fourth wave came, and it was different because by this point, most people had been vaccinated, our numbers were dropping. We felt really good for a change, a little bit of like, we can breathe. We're closing more and more COVID units in the hospital. Like, we had less and less and less. We could open up our ICU. It wasn't a closed unit anymore. We had so little COVID patients because of the vaccinations. But then the fourth wave was, of course, the unvaccinated. And by that point, from a clinician perspective, a caregiver perspective, I think the empathy started to wane a bit because there was just so much. We had to open up another COVID unit again, and it just seems so senseless because these are preventable deaths at this point. All of them, not all, 90% were unvaccinated. You did have a lucky few who were fully vaccinated and still got COVID that were dying from it, but those ones typically had kind of severe, immunosuppression or other like autoimmune issues, like immune disorders. But 9 out of 10 were unvaccinated, and they were young. I remember one patient I had, she was a nurse. She was unvaccinated. She was dying in the ICU, full vent settings, maximal support. I called her daughter in and I called her sister in. Her sister was a ICU nurse. So her sister was in the thick of it and also actively treating all these fourth wave patients. She had asked for like the day off so she could come see her own sister in our ICU. And I just remember walking in, and usually I do my very so sorry to meet you, I'm the palliative doctor, like, what do you need? And this time I just walked in and I looked at them and I said, why are we here? What happened? I said, she's a nurse, you're a nurse. What happened? And they kind of were like, oh, well, mom, mom is just stubborn. She didn't want that vaccine and she just stubborn. And I just was kind of like, she's not going to get through this. She's going to die from this now. I was just very much more blunt and kind of, I've never talked to a family that way again or before. And they weren't upset about it. They got it. I think we were all kind of frustrated, but that's just it was just indicative of kind of like how over it, all of it I was. I just kind of came in like, she's not going to make it through this. This could have been prevented. And I don't think typically I would have ever blamed the patient for their, terminal illness. But in that case, I couldn't help it.
Excuse me, Dr. Van Buren, I want to leave some 20 minutes for questions here. Okay. And there's a question particular to you. So I feel like at this point of your narrative, if you might say, first of all, several people have commented that they appreciate your empathy and your honesty and the way that you're describing how you were emotionally affected by everything that you were living through as you were trying to help patients. A couple of people have asked what preemptive measures could be implemented to help healthcare workers cope with this kind of distress that they've already experienced, and then also the after effects of having lived through this. And I think this question is for you, but I think they also want the opinion of the other speakers.
Sure. So I'll just briefly say that's a great question. And one thing I wanted to say is we heard a lot of lip service during these past couple of years. You get people clapping or horns blowing or whatever at 7 p.m. at night. And it was kind of like that with our own hospital. They'd say, why don't you guys do meditation, yoga, just very, I don't know. It just wasn't really helpful in the moment. What we need is time off. We need time after we have a tragic death, or, we actually need space to kind of deal with that in the moment. We need someone to help talk us through it in the moment so that we can move on to the next case, because it's like you lost someone. All right, there's 10 more people waiting for you now. You don't get a time to decompress and deal with it as a human. And a lot of the things are very superficial. Oh, here's a Starbucks card. Here's a meditation app or whatever. We need real change to deal with this. A lot of it is systematic. We need time. We need days off. We need more workers. Everybody was stretched to their limit. And I just don't feel like the changes that were being proposed were actually going to make a difference in my day-to-day emotional stuff.
Thomas, what are your comments on that?
I'll echo Dr. Van Buren. I think there's a tendency, especially in the literature on things like moral distress and burnout and compassion fatigue, to focus on the way that individual providers can respond, or small groups or teams can respond. And I think that the empirical work and the theoretical work on that is useful. But what I've learned in this experience, trying to think about it as a thinker and then as someone going through it, is these are systems issues. I cannot meditate myself out of this problem. Nurses cannot meditate themselves out of this problem. They need, like the kind of therapy you would get from a traumatic experience, once or twice a week for an hour at a time, a consistent therapeutic clinical intervention. And most likely they're going to need it during the work days, or else they're not going to be able to go home and continue their lives with their families. And so I think my take on that is my individual take, not as a professional employed by any of the institutions I'm employed in, is that the healthcare system in the United States is unequipped to deal with this trauma that's been experienced by providers. And I have heard nothing to suggest to me that it will respond in a way that equips itself. So individuals will bear the burdens, they will respond, some of them will go on, and some of them will change careers, and some of them will suffer larger consequences. I don't think anything else will change that. So I'm very skeptical about the reality from a pragmatic point of view of things changing. And to be honest, I think I lack the competency to imagine a different world. I can't imagine how that would be changed in our current environment.
Felicia, what do you think?
No, I agree. The meditation, yoga, comfort food, they all have their places, but they all have one thing in common, that they require time. And I don't think it's just healthcare professionals. I don't think the world is equipped to really address on an individual level all that each of us has lost in the last year and a half. There's so much that we haven't been able to do, so many human connections, all those things that give our life meaning have not been possible. And until we have the time to reestablish those connections, to take the time with our friends, with our family, away from work without that stress, I don't think any of us are going to heal really well. So it's really just time. And, despite all the efforts that our well-meaning healthcare organizations are making to build renewal programs, it's all going to be lost if we can't give people some time off to do what they need to do, to figure out what it is they need to do and to do it on their own.
So one of the questions received was in general about pandemics. What plans should we be making now for the next time? But I kind of want to stay on this topic. I mean, this topic is, distress in the hospital. Like, I think that the three of you have done a really good job describing what you've lived through and sort of the problems. But if we could creatively think, what are some things that we might do now so that there would be a better future with regards to handling distress? Thomas?
Yeah, so I think these are largely political and public-private partnership kind of solutions. You need more people. You need to take people and train them on how to do the work we do in the hospital so that you have enough of them who are competent, engaged, professional, willing, and able to come in and share the load and to do it in an adequate way. There are probably technological solutions, but you need people, human beings, with love and care and competency to work the machines and to work the system. So, I've heard, I'm not politically, sadly, I'm not that politically engaged. I listen, like I said, I'm a news person. I listen to the news. So I've heard about, for example, like an AmeriCorps kind of equivalent. You need that, but at a scale that I don't hear anyone talking about. We talked about doctor shortages, nurses shortages. Those happened before the pandemic. I don't know the demographics, but my presumption is they've only gotten worse. There aren't enough ethicists to go around. You look at the data on that. There are fewer of us than there were in 2007 when the last studies were done. So you need far more personnel, and those people expect a certain amount of, payment for their efforts and their work, a livable wage. And I think that's the kind of solution. You need a lot of people to do the work, and it's hard work.
Yeah, and I'll add what the context here, the bigger context. We're just one earthquake away from real disaster. This is Southern California. Bad stuff happens, and not just here. We've seen hurricanes and earthquakes and things that just shut down whole areas. And if any of that had happened during one of our surges, I can't even imagine what that would have looked like. People just would have died. We have a healthcare system that is fundamentally unable to take care of people where they are. So when we run out of hospital beds, there's nowhere else to go. We need to rebuild our healthcare system so that it does address people's real needs. And we see it every day. It's not just in crisis. Every day there are people whose loved ones beg for them to stay in the hospital because they can't afford to send them to a facility. They can't afford to get them the resources they need to take care of their ill loved one in a reasonable way. And that's just the tip of the iceberg. And that's under the best of circumstances when our resources are at max capacity. When we don't have enough nurses, which is now, when we don't have enough physicians, which is coming soon, when we don't have the techs, when we don't have the infrastructure, we're all going to be facing disaster.
Oh, this is so cheery.
That's why I was laughing, Gigi, is we're like the bears of bad news. But I will say, as Nicole and I see friends who I know on the call, I'm actually really fun. I'm like a fun person. But what you'll get from us ethicists, is real talk. And unfortunately, you ask us a hard question, and we're going to try to be honest with you, because that's really the only thing we have. that's what we're good at. And so
there are
ask
good things here. I mean, people really did lean in. People were willing to do the work. So we know we're capable of it. We just have to figure out how to make that the system that we have instead of the system that we just desire.
Okay, so here are two related questions, and they kind of go along the bioethical theme. How did you see bioethical discussions and decision-making change during the pressure of COVID? And then related, what are lessons for bioethicists from this experience?
I'll jump in since no one did, and I'll just say, Nicole, I'd love to hear your thoughts too, because not everyone will know this on the call, but you were in some ways kind of a budding bioethicist at the beginning of this and got the whole trial by fire. One of the things that, consistent with the other conversations, I do think we're going to face a shortage of labor in the bioethics market as you have the Great Resignation and the aging of the labor force. And so bioethicists will also become more scarce, and there will need to be changes in the way we provide our work to hospitals and other systems, because there will just be fewer of us to go around. Like with other fields, you can't just grow a bioethicist, right? You got to go through many years of training and credentialing. And so we may need to start thinking differently about the way that we credential people. Typically we're accustomed to a doctorate of some sort, plus a fellowship, plus advanced, apprenticeship. We may not have that luxury if we actually want to staff it up. So we may need to think of a more hierarchical staffing model or something like that to meet the needs. That's one thing on top of my mind. And I think that the tensions between things like justice and decision-making in real time have been very enlivened by the work. And we haven't talked about the, racial injustice protests in LA that happened and were very much part of the fabric of the moment of all the times we were talking about. But I think that once those have, speaking personally, once you see that and you see those injustices really manifest in kind of ways that you just cannot unsee, I think that's part of what bioethics is going to reckon with ever more so than it used to. And it was always part of what the dynamic of bioethics, thinking about that. Now it's in sort of most patient care experiences. It's just think like, is that here now? And usually it's not, but when it is, it's more obvious, and I think it's more obviously something that has to be worked through.
So the 2 points of these questions, one was under the stress and pressure of the pandemic, did bioethical discussions change that you noticed? And then the second one was, what lessons do bioethicists take with them from this pandemic experience?
I would say, just from an and I'm not a bioethicist, but just working with Thomas, bioethics really shined during this time in a way that nobody knew what to do. Nobody knew what was the right thing to do. It's almost like people couldn't even begin to think about how we even think about how to solve some of these problems. And working with Thomas showed me that bioethics is a lot more than I ever thought it was, that because you come at things with the lens of how do we do the right thing, or is the best thing in this very tough situation. We were kind of a leader in our own hospital. We shaped a lot of, like I said, policy in terms of visitation, triage. They were looking to us for those answers, the administration. And so we had a lot of respect that I don't think we had before the pandemic. And it was just a real opportunity when things are happening and nobody knows what to do, to be able to look at a bioethics the body of bioethics and say, how do we even begin to think about this in the right way? And we were used to writing policy, and we got to help our hospital in really meaningful ways during this time. I think they appreciated it.
And I think I agree. Under pressure, the foundational nature of bioethics really emerged. That, by its very nature, the practice of medicine is all about asking, what should we do? And that is, the fundamental ethical question. I think that really came out. I think one big thing that changed is, as a bioethicist, I give recommendations. I don't give answers. And yet, during this time, I feel like I've been giving answers. And I feel like I've been doing that because that is what people need. Just like when we're kids, sometimes you need your mom to tell you what to do, and you need to be able to blame mom when you do it. People needed that. And I would see notes saying, bioethicists said, or just quoting a recommendation as if it was gospel, which made me really uncomfortable. So I had to step back and remind myself, this is what they need at the time. This is how it's going to work. And it's not what I said, but it's how it's interpreted, and I'm going to live with that.
That's very interesting. It's a really interesting point, Felicia. Okay, so I have maybe time for one more question that if each of you could answer, like a very kind audience member really wants to know, what would have helped you as you were going through this? If we know healthcare providers or bioethicists or hospital administrators who are at their wits' end as they go through this kind of stressful situation, how can we help them? Or how can we advocate for you, the frontline workers? What would have helped each of you as you went through this?
I think for me, it was recognizing that I'm human too, that I don't have all the answers, that I can't fix everything. I don't have a magic wand. And it was stressful for me too. I think sometimes we look to our leaders, and in this case, I feel like we were leaders, and want to lean on them without realizing that maybe there's not a wall against which for them to lean as well.
I think forums like this are really good. I think one of the things I learned in the experience is, and this is a weird word for me, but something like indemnity. And what I mean by that is there was a lot of feeling that you couldn't be honest in the wrong place. There was so much happening that I felt like if you're in this hospital, you can talk to each other in a way that you know what the background is, you know who you can trust, you know who's been there. I think that's part of what I got from Nicole's talk about the war metaphor. My perception of the current public environment is that you can't be that way too publicly. You can't be that honest. And so creating space and holding that space open for someone who you may know who's going through this to be honest and thorough in a non-judgmental way, and to ask questions and to just give them that ear and that platform, I think is really valuable, because a lot of what I think the distress comes from is the perception of either not having enough time to be honest and talk through it and reflect, or not feeling like you can do that without being held accountable. And I think we need a space to be able to be honest and maybe say things that come off as offensive or wrong-headed or mistaken, and then be able to say, oh, thank you for letting me say that. Let me repeat what I said in a different way so it's not offensive, because it's really what I meant. And I think our public discourse doesn't open that space, and I think it's very flattened and simplified, and it's more sensationalized and sort of what's going to gain views and clicks and that kind of thing. And I don't care about clicks. I care about getting on with my day and helping the people I'm around. And sometimes I might say something that's going to be click worthy, and that's not the thing I want to say for that reason. It's why I want to say it because I got to get through it. So I think we lack that as a community largely. And so that's something on my mind that I think would help. And I have good colleagues, and I have somewhat, the network of people I trust. The other three of you on this screen are those people. But I think, I cultivate that, but not everyone does. Not everyone is disposed to have that kind of network. And so if you know those people and you love them and you give them some space, that might be really good for them and for you.
And how about you, Nicole?
Yeah, I have to say, I feel really fortunate. When I look back on that time, I don't think of this is what I needed to get through it. I just feel gratitude for I had everything I needed to get through it. I think as tough of it as it was, it couldn't have been any better than it was. I had Thomas, I had my partner, I had my chief, my area medical director. Everyone was so supportive and appreciative of our work, and kind of, you have a lot of imposter syndrome when you're not used to being a leader. And I had support. I mean, me and Thomas were on the phone, like, I think our spouses hated us. We were on the phone like day and night, just my thought partners. So it's what Thomas said. It's community, it's support, it's mentors. That's what I had, and that's what one needs.
Well, that is a lovely way to end this event. Thank you very much. The three of you, Kaiser Permanente was well represented tonight, and that was just a lovely flavor for our lecture series. This has been recorded. We'll do some light editing and it will be posted on our website. I'll make sure anyone who has registered for this event will receive an invitation and a link to be able to view it again. Thanks again, Thomas Cunningham, Felicia Cohn, and Nicole Rae Van Buren. I appreciate your honesty and your willingness to jump outside the normal box of academics and talk a little bit more from the heart about how this pandemic has affected you in your work at the hospitals. So on behalf of the Bioethics Institute, thank you very much.
Thank you for having us.
Yes, thank you very much for listening.
My pleasure.
All right. Good night, everyone.